morning, everyone.
Good morning.
So today I wanted to talk to you about one of the most pressing challenges in modern oncology, not how to treat cancer, but why it keeps coming back. Despite huge strides that modern surgery, chemotherapy, radiotherapy, and immunotherapy had, resistance to therapy remain one of the leading causes of cancer death. And I hope by the end of this talk you'll understand why and what we can do about it. Consider this scenario. A patient is diagnosed with cancer, undergoes standard of care therapy, and initially responds well. Markers stabilize and tumor size reduced. But then, months or even years passes, and the tumor returns. But now the tumor does not respond to the drugs that was administered in the beginning. Why does that happen? Can anyone
Because the tumor maybe changed the micro-environnement. Elle a changé. Les cellules.
Yeah, that's one reason. Also, microenvironment also plays a key role, and we're gonna take a deeper look at it later on in this presentation. Now, this problem is not specific to one type of cancer. It recurs in glioblastoma, in lung cancer, in triple-negative breast cancer, and so on and so forth. And understanding why this happened is not just an academic question; it is a crucial, question to answer that can determine whether patients live or die. Now, there are two types of resistance. There is intrinsic resistance, which basically means that tumor never actually was never actually sensitive to therapy. When drugs was administered in the beginning, the tumor cells resisted it, and we don't even see initial response. Adaptive or acquired resistance, on the other hand, works differently. Tumor initially responds to treatment, but subclones, even if they are little and little cell, small number of cells that resist, do exist within the tumor. And when the drug initially eliminates all the sensitive cells, it allows the resistant ones to grow and to proliferate, and after a few months of treatment, what we have is a tumor that is dominated by resistant cells. Now, these two types of resistance exist within the same, we can find them within the same patient. And understanding how to distinguish between the two is crucial for treating said patient. Now, cancer cells are genetically unstable. This genetic instability is actually beneficial for them because drugs actually can act as an evolutionary pressure, eliminating sensitive cells, but allowing resistance one to grow. Now, the genetic instability comes to play when, for example, we're administering one drug. But now, what can happen is that the gene for the protein that is targeted by that drug can mutate, and now it no longer and now the affinity of the drug to that protein is reduced, and therefore it renders it useless and ineffective. Another really important mechanism that targets that tumors have in their arsenal is bypassing pathways. What tumor can do, for example, we're targeting protein 1, a tumor can activate alternative pathways that bypass that protein that we're targeting, and thus exact same function. This process is called pathway redundancy. And finally, one really prominent example that I want to highlight is the EGFR mutation. Now, for example, in lung cancer, targeting EGFR is initially really effective. But after a few months, what we notice is the appearance of this mutation, which is the T79M mutation. And this mutation essentially renders all the first generation EGFR blockers ineffective. And therefore, it makes treating this cancer really challenging. And now we come to what Nasima just mentioned, which is the tumor microenvironment. Now, for tumors to resist therapy, it cannot do it by itself. It needs support. And one of the main pillars of support for tumors is the tumor microenvironment. Now, tumor microenvironment is a complex environment that is made from fibroblasts that can act as a barrier, and this barrier can stop drugs from penetrating. Can also stop anti-tumoral immune cells from penetrating the tumor. Another important aspect that I want to highlight here, which is the tumor heterogeneity. Now, when we think of tumor, we should not think of it as one homogeneous blob of cells. It contains many subclones. And these subclones, some are resistant, some are not, some have their own vulnerabilities, others do not have these same vulnerabilities. And this consists a really difficult challenge specifically for diagnostics and for determining what type of drug we need to administer. And
also sometimes we can find that our cells and our immune system cells can also inhibit the work of T cells. Like Treg cells, they can attenuate the work of our immune cells, and like that, cancer can grow and spread.
Exactly, like she mentioned, Tregs are protumoral cells. They can hinder the work of. So when we're talking about cells that combat tumors, we're mainly talking about two main subpopulations. There are the CD8 T cells and NK cells. Now, like she mentioned, Tregs play a protumoral role. Also, we have molecules like some cytokines that can inhibit the work of our anti-tumor immunity. Also, why is tumor heterogeneity considered a challenge for diagnostic and for biopsies? Can anyone of you think of what may be the reason behind that?
We cannot specify the type, maybe? What is
Yeah, kind of. So let's say, for example, this is the tumor, and the doctor tries to take a biopsy, and then he sends it to the lab. The biopsy is analyzed. Of course, a biopsy is just a small part of the tumor. The thing is, our tumor is not homogeneous. So when we took this part, for example, it expressed certain markers, and we know, okay, it expressed this marker, we can target it, we can cure this tumor. However, on the other side of the tumor, maybe it does not express these markers. And this is really challenging, because to understand that tumor from one biopsy is really difficult. Now, the next slide is also about tumor microenvironment. It's exactly about what you just mentioned. Here, for example, about what I mentioned about fibroblasts, how they can form a physical barrier stopping drugs and stopping also anti-tumor immune cells. Also, immunosuppressive signaling, PD-L1, PD-1, CTLA-4, these are all immune checkpoints that inhibit anti-tumor immune cells. Some immunosuppressive cytokines like TGF-beta and IL-10 also inactivate lymphocytes, and also the hypoxia can make the microenvironment more hostile and difficult for immune cells to act. Now, one of the main therapies that we rely on to combat tumors is radiotherapy. Now, does anyone of you know what is the main target of radiotherapy?
Immune cells. No. We suppress the immune cells
The region
before.
of the cancer, but you're gonna attack all the region. He didn't recognize or specify between the healthy cells and the cancer cells.
It
So-
does, but why it does that? Because radiotherapy mainly targets double-strand DNA, and it tries to destroy it. And by destroying it, it will trigger apoptosis and their cell death. But tumors are smart, and they can, what we do, they can overexpress mechanisms that repair that DNA. And they can also suppress mechanisms of apoptosis. And this way they can survive and proliferate more. Now, another kind of therapy that you surely have heard of, which is chemotherapy. Chemotherapy acts in another way. They act through chemical reagents that have to penetrate the cell and again and trigger apoptosis and cell death. However, again, tumors have their way to work around it. They can overexpress efflux pump, and therefore, before even the molecule have time to trigger cell death, efflux pump just takes the molecule out of the cell. They can also trigger enzymatic inactivation of the cell. So like CIF, which just take the drug and destroys it. They can also overexpress certain molecules that are important to stop apoptosis, like BCL2, and also they can suppress a gene that is really important in the work cancer that we call the guardian of the genome, which is the P53. P53 is really important for triggering apoptosis. Once it detects something funny in the cell, it triggers its death. But cancer cells can also can find their way to suppress it. So all these mechanisms make it really challenging to eradicate cancer cells. Now, let's just say for the sake of the argument that we have successfully eradicated 99% of cancer cells in our tumor. One privileged subpopulation of cancer cells, which is the cancer stem cells, have the ability to regenerate the entire tumor. They can regenerate, they can differentiate, and when we are targeting initially the tumor with radiotherapy, with chemotherapy, they are in a dormant state, so they're not proliferating a lot, and therefore our drugs and our chemotherapy, our radiotherapy that is specifically destined to target cells that proliferate rapidly simply does not see them. And they also express a lot of efflux channels, efflux pumps, and therefore they kick the drugs rapidly. So targeting cancer stem cells is at the heart of cancer research, specifically in really challenging cancers like glioblastoma, which is brain tumor. Now, we know all the challenges that we face, but how can we actually answer to all these challenges? Now, simply the answer is not one magical drug. It's tumors have many ways to overcome our medicine. So what we have to do is to target it from multiple sides. So combination therapy is the way. Also, targeted therapy and biomarkers. We have to understand the patient, understand what biomarkers is expressed to know exactly what kind of drugs and what kind of medicine we have to give him to treat specifically his tumor. And finally, there are many new therapies like immune therapy that, if you remember, I said like immune checkpoint. So immune checkpoint blockade is gives really promising results, specifically in certain types of cancer, like lung cancer. Other types of cancer, like gliomas and glioblastoma specifically, do not respond to immune therapy. But glioblastoma is basically a death sentence. It does not respond to any any therapy that is given to it. It's basically even it's given. We start by surgery and then concomitant radio and chemotherapy, and then followed by radiotherapy and chemotherapy afterwards, and still it keeps coming back. And overall survival time is really short. So what are the key takeaways? So to summarize, therapy resistance is not a single event. It is a combination of many factors, and the path forward is personalized. It's biomarkers guided, and it is specific to each patient. And for us to combat this resistance, we have to understand the specific case of each patient, and to give a therapy that is personalized to that patient, because tumors are, as I said, mutate rapidly, and it's really difficult to give a drug that is generalized, that can treat the one drug treats. And thank you for your attention. I'm ready to take questions if you have
I have a really dumb question.
There's
Just
no
about
dumb
the title.
Yeah.
Can you go to the title, please?
First slide.
Yeah, the first line. So it's resistance in oncology or cancer?
Well, oncology is the science of the study of cancer.
In cancer. So it's in cancer.
Yeah, but I mean, you can go by both. In cancer, it is correct, because we're talking about cancer. But what the title is trying to say is, what are the challenges that we're facing in oncology? What are the
studies?
Yeah.
Okay. Thank you.
You're welcome.